Hello, everyone. Welcome to Aohua Vet webinar. I'm the host, Jason from Aohua. Aohua was established in 1994. We focus on endoscopy system for 29 years. At Aohua, our goal is to increase accessibility and convenience when it comes to endoscopy diagnosis and treatment. In line with this mission, we are thrilled to announce our webinar series, which aims to bring together veterinary endoscope users to share their knowledge and experiences. This webinar series will take place monthly by providing a platform for open discussion and the sharing of ideas. We hope to contribute the continued growth and development of the veterinary endoscope field. Okay, next, let me introduce our speaker today, Dr. Vasiliki. Her clinical interests include canine and feline gastroenterology, nutrition and diagnostic, interventional endoscopy in companion animals. She holds a GP cert in small animal internal medicine and a GP cert in endoscopy and endosurgery from the International School of Veterinary Postgraduate, and a PG cert in small animal medicine from Harper Adams University. So it's your time. I will give you the host, Dr. Vasiliki.
Thank you, Jason. Thank you. First of all, I want to thank Aohua for the amazing opportunity to interact with my colleagues all over the world and to share what I love most, being a clinical practitioner and especially endoscopy, both diagnostic and interventional. And we're going today, first of all, before starting the presentation, I want all of you to be invited in YouTube channel, in Aohua YouTube channel. It's called Aohua Vet, where every month we're going to upload a clinical case for you from zero to diagnostics, from the clinical presentation to diagnostics, to endoscopy and also to treatment. So it's not going to be just only endoscopic procedures, but it's going to be a whole case based approach so that you can see how and follow the know-how and follow the case. And also everything will be recorded and uploaded also to Aohua YouTube channel, which is called, as I said, Aohua Vet. Okay, let's share screen and start today is going to be a very interesting presentation, because it's not going to be general as the first part, which was mostly the introduction. It's going to have a lot of cases on, let me share screen, a lot of cases on gastric and intestinal diseases. Okay, let's go. And of course, please put your questions, even if they are relevant to the cases and they are not purely endoscopic questions, even if they're internal medicine questions relevant to the cases that we will present. Okay, so let's start. For those of you who missed part one, I really wanted you to know a bit about the patient preparation, what we do before we enter an animal to our endoscopic hall. And I have a cat here, as you see. We have to, as clinical practitioners, exclude all the extra intestinal diseases before guiding an animal for endoscopy. So we have to have a complete history, a full physical examination, blood work, plain radiograph. Sometimes vomiting and diarrheas are just secondary symptoms of a secondary disease or of an extra-intestinal disease like Addison's, like other metabolic diseases, renal, liver failure. So you have to exclude pancreatic diseases as well. You have to exclude all the extra-intestinal diseases in order to be guided to endoscopy. And endoscopy is not going to give you the definite answer to an animal that hasn't done all the preclinical workup. Okay, so it is mandatory to have at least 10 to 12 hours of fasting. General anesthesia is obligatory, and intubation with a cuffed endotracheal tube is obligatory as well, because we don't want to have gastroesophageal reflux and have aspiration pneumonia to our patients. And also because sometimes we don't know what we will encounter during the endoscopic procedure, so we have to have the animals under controlled general anesthesia. The sedation part, it's differentiated according to our preferences, for example, and it depends also on the medications that you have in each country, because for example, the medications that exist in Europe do not exist in the Middle East, or in some parts, at least, of the Middle East. So you have to do the sedation that you're more familiar with. Always put your patient in left lateral recumbency, as the cat here. And the only reason for putting the animal in right lateral recumbency is when we put a PEG tube for gastrostomy, a gastrostomy tube. Okay. Now, let's see what are the endoscopic findings, the macroscopic, though, findings of a normal stomach. The stomach should be empty after 12 hours fasting, which means that if you find food, if you find gastric contents that are retained after 12 hours, this implies delayed gastric emptying, and some small amount of fluid in the fundus is normal. Could be bile, could be gastric fluids. You will see them in the videos that will follow. Rarely a small amount of bile in the antrum. A big amount of bile in the antrum implies that there is a degree of duodenogastric reflex disease. So a small amount is acceptable, but a big amount should imply other things and that we should be suspicious of. The gastric mucosa of the stomach is pink and glistening. I will show you to a video. Some foam also may be present in the stomach. The antrum mucosa is more grayish, more pale than the fundus or the body of the stomach. The rugal folds are on the greater curvature, and all the rugal folds always lead you to the pylorus. So if you're lost, if you're inexperienced endoscopist and you don't know where you are, you will always follow the rugal folds. The rugal folds will lead you to the pylorus. Okay. And when you inflate air in the stomach, because the stomach is like a balloon. So when you inflate air, then all the ruga folds should be flattened. There shouldn't be remaining ruga folds. If they remain, like giving the figure of a brain, we call that cerebroform lesions, then this implies hypertrophic gastropathy. And I will show you some cases of that as well. Submucosal vessels seen in the cardia and the fundus only, not in the antrum. In the antrum, we don't have rugal folds. The rugal folds lead to the antrum, but they're very, very few in numbers compared to the body and the fundus of the stomach. And the pylorus is a star-like shape appearance. Sometimes it's open, and it depends on the anesthesia. We cannot judge if this is normal or not. But if, for example, you have a delayed gastric emptying and you don't have gastric peristalsis, then this might mean that you have hypomotility, some kind of hypomotility disorder. So let's go and see what a normal stomach looks like. These are the rugae. I haven't inflated the stomach too much. Please do not inflate the stomach. For those of you who do not attend part 1, again, do not inflate the stomach with a lot of air, not because of the bradycardia. That's on your anesthesiologist, but also because you will not be able to tangle your way through the parts of the stomach. So here you see a lot of foamy material, but it's a glistening pink mucosa. There's nothing wrong with this mucosa. Okay, and there's a very good question here. If I don't find any lesions, if macroscopically my stomach is normal, should I take biopsies? Of course, because in the stomach, even if we don't have macroscopic lesions, we may have microscopic infiltration. And as you've seen right before, let me go here again. This is the J maneuver, which means that I'm looking at the cardia. I'm looking at the, this is the esophageal, this was the esophageal sphincter. And let me, we have a problem with the internet connection now. Let's wait for a second. So the first thing that we do when we enter the stomach is that we go in, inspect the body of the stomach, and then we retrospect 180 degrees back. This is a J maneuver. And we have to do that in order to inspect all the parts of the stomach. Let me go, because I have, again, an internet connection problem. I'm sorry about that. Let me ask. I will share screen again. I'm sorry. And I will answer the question that you have. This always happens in life. So, okay, let's go. Share screen again. I'm sorry. Okay. I hope that you can see me now. Please go to the chat box and say if you can't see me. So as you see, all the rugae are pink, glistening. What about this lesion here? Can you see this lesion where I point here? This was because of my scope. Sometimes you suck, when you have the suction, you suck the mucosa and you leave marks on the mucosa of the stomach. So please assess these lesions and know what you have, what are artifacts and what are not. Okay, let's see the chat as well. Okay, you can see the screen. Thank you. Thank you, Robin. Oh, hello to Spain. Many, many greetings to Spain.
Hello, Vasiliki.
Yes.
Yeah, we are in front of the computer.
Okay, that's great. That's great. Let's see. You're watching me normally, Robin. No problem, huh?
Yeah, it's no problem. The image
let's see now the parts of the gastroscopy. First, the first movement that we do when we enter with our scope is inspection of the body. This is our first movement here. And this is what we see. This is the area that we inspect. So right afterwards, we do the J maneuver, okay, which is, this is the incisura angularis, which divides the stomach in two parts, in the fundus and in the pylorus, in the antrum, actually, in the pyloric region, the antrum. And so we go in, we retrospect 180 degrees in order to do the J maneuver. And then this is the incisura angularis. You see, this is exactly the place that we're inspecting. And actually, this is a very, very important landmark in the stomach, because if you don't know where you are and you see the incisura angularis, you know that on the left, it's the fundus, on the right, it's the pyloric, the antral region. Okay. And then, of course, it's the pylorus. We proceed into the pylorus. This is an open pylorus here and here as well, a mildly open. And it has these folds, and we will see the significance of the folds in some videos. Okay, now, when we biopsy the stomach, we biopsy from each and every part of the stomach, not only from the parts that you will see lesions, okay? Biopsy, take at least 1 to 2 or 3 biopsies for each and every part of the stomach, because you might have different infiltration types, you might have mixed infiltrative diseases, so you should know all of those things. And also in the antral region, this is the region that you will find most of the times the HLOs. The HLOs are the Helicobacter-like organisms. We don't have Helicobacter pylori in dogs. In cats, yes, it has been found, but in dogs, it hasn't been found. And Helicobacter organisms, there is a dispute and a discrepancy if they can or are not able to cause gastric disease. And the bottom line is that they can cause gastric disease under certain circumstances. Let's see now. Oh, and another thing is that if you overinflate the stomach, then you will not be able to take good bites, good biopsies. Okay. Now, let's go now and inspect one by one possible diseases that we might encounter while scoping, because it's not everything, it's not all about scoping, it's about knowing what's behind the lesions that you're seeing, that you're watching, okay, and observing. So the gastric hypomotility disorders due to outflow obstruction, and the outflow obstruction is when the flow from the stomach is embedded, is not easy towards the intestine. This can be caused by two main categories. We might have a mechanical obstruction or a functional obstruction. What is a mechanical obstruction? A mechanical obstruction could be due to hypertrophic piloropathy, which I'm going to show you, about hyperplastic mucosa only of the pyloric antrum. And this is a disease that could be diffuse or located only in the pyloric region in certain breeds. Neoplasia, foreign bodies, external compression of the pyloric region from neoplastic masses of the pancreas, for example, of duodenum masses. All of these things can obstruct the outflow, the pyloric outflow, and this causes actually projectile vomiting to the animals. Either cases cause projectile vomitings. And the second category is functional obstruction. What is functional obstruction? When we have, for example, an infiltrative disease, an inflammatory bowel disease, an eosinophilic gastroenteritis, or a neutrophilic gastroenteritis, or a lymphoplasmacytic gastroenteritis, then this causes hypomotility due to the infiltration. And this is not a mechanical obstruction. Then we have a functional obstruction. The stomach does not function as it should properly. And of course, any extraintestinal disease, like for example, if you have an animal that has acute pancreatitis, then you will observe that there is a huge amount of gastric hypomotility. If you have, for example, Addison's disease, it's the same thing. Or if you have, for example, hypothyroidism, hypothyroidism can cause hypomotility disorders. Okay. Now, let's go to the delayed gastric emptying. What do we find as endoscopic findings? We have, when you have delayed gastric emptying and not normal contractions of the stomach, then you have a big retention of gastric fluids or whatever other gastric content you have of digested food, of partially digested food in the stomach. You have what we call a gastric paresis. You do not have a contraction. The normal peristaltic waves are normally addressed for the intestine and not for the stomach. For the stomach, we say that we do not have normal contractions. And also the rugae are thickened and they do not flatten while we insufflate, while we put air in the stomach. We have a light reflectivity, and that light reflectivity suggests edema. This is a very glistening light on the stomach, which I will show you. And also, let's see, and you might have also some, due to the delayed gastric emptying, you also might have some gastroesophageal reflux disease, and you will see in the cardia that you have proximal to the lower esophageal sphincter some signs of esophagitis. Let's see the video. So you will see that this is this actually, in order to see your scope, this is in J maneuver, and you have seen that this part of the fundus was like a brain. This is called cerebriform mucosal lesions, and I have insufflated so much the stomach that the rugae are not visible in this side, but in this side, it looks like a brain. Okay. This actually is hypertrophic gastropathy, and not pilorogastropathy. That was hypertrophic gastropathy. And there is this actual disease, which is called, in humans, it is called Menetrier disease. In dogs, we call it Menetrier-like disease. And we have these cerebriform lesions that are mostly in the corpus, in the body and the fundus of the stomach, and they're missing from the antrum and the pylorus. So the antrum and the pylorus are normal, and we are finding these lesions focused mostly in the body and the fundus of the stomach. And this is what differentiates Menetrier-like disease from hypertrophic pilorogastropathy, because in pilorogastropathy, we have hypertrophic lesions in the antrum as well. So this disease was actually, this is from an article that was published in 2021. It's free access, so you may all have access to have a look at it. It was in a pointer, and that had also concurrent granulomatous gastritis, Helicobacter, and leishmaniosis. This disease has also been showed in a boxer, only 7 cases. In Old English, at least only 7 cases reported, or people who knew what they were seeing and they reported it. A Westie, 3 Cairn Terriers, and a Jack Russell Terrier. And the main endoscopic findings were the cerebriform, as I told you, lesions that are sparing the pylorus and the antrum. Let's go now to delayed gastric emptying due to mechanical obstruction. What can cause a mechanical obstruction? We kind of said the causes. So it could be congenital thickening of the smooth muscle of the pylorus, and it could be not diffuse, could be only localized in the pyloric region, but also it could be a more diffuse disease. Gradually acquired hyperplasia of the smooth muscle of the gastric mucosa, neoplasia, polyps, foreign bodies, of course, mechanical obstruction, and extra gastric compression. It's mostly seen in brachycephalic dogs, in boxers, in Boston Terriers, in Maltese, in Pekingese, Lhasa Apso, and Shih Tzus, and it has been also seen in cats, in Siamese cats. Let's have a look at that. So this is mechanical obstruction due to, it's very obvious, due to a foreign body. And as you can see, the foreign body has obstructed it's like a mass in the pyloric region. Watch out for these linear foreign bodies. We're going to talk in another lecture about foreign bodies, but watch out for these foreign bodies that are like, this is tie shoes, I think, that we have got out. The linear foreign bodies, some of them could be in the intestine, and a part of them could be remaining in the stomach. So do not push hardly unless you're sure that the whole linear foreign body is in the stomach. Okay, so this was an obstruction due to this foreign body. You see that the mucosa is uneven. is not normal due to the persistence of the foreign body. So I go in with my forceps and try to see, first of all, the tension. So don't go and grab it forcefully, but let's, as a start, try the tension. I have a question here, I think. Let me see. I cannot see the attendees that raise their hands. If they want to talk, please. Who raised their hands? I do not have access to the attendee. I cannot see who raised their hands. If somebody wants to talk, please take the unmute and talk, or just pose your question.
Vasiliki, you can see the attendees raise hand in the attendees function.
No, I cannot see that. I cannot see that. I do not know why. Maybe in the more, no.
The attendees cannot speak until you give their.
Yeah, but they can actually put their questions in the chat or in the Q&As. Put your questions there and I will answer simultaneously as I'm talking. Okay.
Okay.
Now I can see that you raise hands. Let me see. Okay, now I can see that. Whoever wants to talk, please put your I can see that 2 raised hands, but I cannot see their questions. Place your questions and I will answer the questions. Okay. Tanya, Nikos, and Nikolai, please. What should I do? Allow to talk. Okay, Tanya. I found the way. Tanya, please talk. Do you want to talk, Tanya, or not? You have to unmute. Can you hear us?
Maybe we can put the question in the Q&A.
I have to unmute you. Let me unmute. I cannot unmute. I'm sorry. Oh, here, maybe. I cannot unmute. I'm going to go on. Whoever raised their hands, please put your questions in the chat box and I will answer them. Okay. Or Jason, please help me how to unmute these participants. Okay.
Okay, I will help you. Please go on.
Okay. So let's have a look at mechanical abstraction due to a neoplastic mass. Sometimes we have mechanical abstraction due to a mass at the lesser curvature, here, for example, or at the pyloric region. Let's see here the mass extending to the pylorus. This was actually an adenocarcinoma that was in the lesser curvature and had invaded the whole pylorus. You see the gastric retention when you enter the stomach and you see this retention of fluids, then you should be suspicious of something obstructing the pylorus. Okay. And you will see the mass here. So you saw the gastric retention. You see that it's pooling and it's bile actually, and gastric contents. And now we're trying to insufflate all the gastric fluids in order to see what's going on. You see how much of a fluid it is there. I do not want to touch to speed it up because it might cause problems in the connection again. So we will have to see. Whenever you have gastric content, you see the mass here. You see the mass here. It has ulcers. It's ulcerated, but we revealed that after we took out all the gastric content. This, you can do that as well with a gastric tube just prior to your endoscopy. If you see with an x-ray that the stomach, or with an ultrasound that the stomach is full, then you can empty the stomach in order not to do that with your scope, especially if it's a big amount of fluid. So now you see the mass, and this is the pylorus actually. This mass is standing right next to the pylorus. And it's forbidding all the gastric contents to enter the intestine. And let's go here as well. This is our pylorus, and this is the gastric mass. You see how proximal it is and with how big of affinity this mass is next to the pyloric region. And of course, we always biopsy in the periphery. If there is an ulcer, we always biopsy in the periphery of the ulcer. And these masses are really, really, if there's not an ulcer, you can just biopsy the mass, but these masses are really, really tight. And so sometimes you have to biopsy over the same region over and over again. Do repeated biopsies in the exact same spot in order to get a very good chunk. And sometimes it's very, very slippery. You cannot biopsy because they are very hard, like a foreign body, like a ball, a tennis ball, that hard. So you can go with your forceps, and the forceps, you will see that your forceps is slipping away from the mucosa. Nico, you want to say something? I know. Please put your, Jason, can you please help Nikos to unmute?
I thought you should allow Nico to.
Yes, I did. I allowed to talk, but then I have to ask to unmute, and I cannot unmute.
I thought it would be the same way.
You have to unmute yourself. I asked to unmute, and nothing happens. This is the problem.
Yeah, maybe they should allow. They should unmute themselves.
Yeah, Nico, can you unmute yourself? If you can unmute, please proceed and ask me whatever you want. And also, Alan, I will allow you to talk as well. And please unmute.
Okay, yeah, I mute now.
Oh, great. Alan is the first one. I didn't do anything. So the other two have to unmute. Please, Alan.
Yes, I unmute. So
no, you wanted to ask something.
Would you what?
You raised your hand. Did you want to ask something?
I think I did the wrong type. Sorry, the wrong type.
No, that's okay. That's great. It's nice to meet you. I hope you enjoyed the lecture as well.
Sorry.
No. That's great. Okay, let's mute again. Let's proceed. Okay, and this is an antral polyp. This polyp has not actually obstructed the pylorus yet, but it will eventually, if we leave it, get bigger and bigger. But this mass here, even if it's a polyp, will cause gastric hypomotility and antral hypomotility. So this means that this animal actually, this dog was vomiting and was not responding to common antiemetic treatment. Let's go and have a look. So do I have to biopsy that? Can I say macroscopically it's a polyp? Of course, you always have to biopsy lesions. Okay, and you will see here that there is a pyloritis. There is an inflammation in the pylorus, and the pylorus is open. Could this be due to sedation? Yes, could be due to sedation. Could this be due to hypomotility disorder? Yes, could be due to hypomotility disorder. So we always biopsy, and I think that here I am biopsying in this video as well. And it would be great if you could take 2 or 3 biopsies from the mass. And as I said, it would be better to do that at the same spot every time, not different spots, because you want to go deeper and deeper in this lesion. Okay. And as you see, it's people think it's very easy. For polyps, it's easier than adenocarcinomas, for example, because polyps are much less, are much softer. And also, if you watched what I did, is that when I go to the mass and grab it, I take out air from the stomach because I want all the tissue to come up to my forceps. So you go, you grab, and then you suction, you take out the air so that all the tissue comes up on your forceps, and then you slowly grab the tissue. This gives you better bites, better biopsies. Okay, let's see what findings we have in gastritis. And what kind of gastritis do we have? The infiltrative types, you know them: lymphoplasmacytic, eosinophilic, neutrophilic. Most of the times life is, is not that, or medicine is not that that easy, black and white. Sometimes you have mixed, and most of the times you have mixed infiltrations, except chronic diseases that are mostly lymphoplasmacytic. Okay, so as we said, the stomach may appear grossly normal. This doesn't mean that you will not get your biopsies. We may have increased mucus and increased number of follicles, of lymphoid follicles, and I will show it how it looks in the videos. We can have mucosal friability, thickening, granularity, mostly in the intestine. Erosions, we might also detect erosions or ulcers, reduced sized or reduced numbers of rugal folds, prominent vessels in atrophic gastritis, and abscess of peristaltic waves, which are not called peristaltic waves. Actually, it's, as we said, gastric contractions. Let's go and see. This dog had diffuse gastritis. And as you see here, we have gastroesophageal reflux disease. This is the Z line. Do not mistake the Z line as gastritis or as esophagitis. This is the transitional line from the esophagus to the stomach. And here we are, the J maneuver. You can see that the stomach, this is a diffuse gastritis. The stomach has patches of hyperemia, edema. We have some foamy material and saliva, which are in normal stomachs as well. Alan, thank you, from the United States. Okay. And let's go on. We leave then the J maneuver, and we will go to inspect the antrum and the pylorus. You see that all the rugae lead to the pylorus. If you don't know where you are, you will follow, as I said, the rugae, and they only lead to one way. Now we're back in the esophagus because I wanted to take out some air, and I had made a loop. Whenever you make a loop, which means that you use more organ than you should, then you should go back and straighten your scope and then go in again, but with less air in the stomach. Okay. And you have seen the radiance of esophagitis in the esophagus that goes circularly. Okay, so now I'm seeing the rugae. Here Where you see the spot of less rugae, this is where the pyloric region, the antral region is. So even if you go blindly, if you just close your eyes and go blindly into the stomach, you will reach the pyloric region. This is the region that you will always reach. And you see here the pylorus that's overfolded and tightly closed. Okay. This overfolded pylorus can be seen sometimes in hypertrophic gastropathy. This dog didn't have a hypertrophic gastropathy, but overfolded pylorus could be a lesion, could be abnormal, but it also can be normal in some dogs. So you have to actually estimate all the surroundings and everything in the stomach in order to say that this is normal or abnormal, and also take biopsies, because if you find fibrosis, then it's hypertrophic gastropathy. Let's see a dog with eosinophilic gastritis, and the most often question that I have is, can I detect if it is eosinophilic or if it's neutrophilic or if it's lymphoplasmacytic just from the macroscopic lesions? Of course not. If we did that, then we would be gods, not, doctors. Of course you cannot. You have to take biopsies for that. Let's see a canine patient with eosinophilic gastroenteritis. And actually, you see a lot of retained food in the esophagus. This dog has esophagitis stage 2 or 3 to the Savary-Miller classification system. You see that we have radiants of linear lesions of esophagitis that are in circumferential disposition. And here you can see these lesions of esophagitis. And when we go into the stomach, as you can see, it's a very bad situation. Ulcers, ulcerated lesions, retention of food. This dog actually, has abdominal discomfort, and in order to help its digestion, eats, this is called pica. This dog eats everything or licks surfaces. These are the hair of its owner. So licks all the surfaces of the house. This is one of the primary symptoms of maldigestion disorders. And you can see a lot of lesions, ulcerated areas. And of course, you will biopsy these areas, and this was due to eosinophilic gastritis. Watch out for Rottweilers and for other breeds that could be prone to hypereosinophilic syndrome. Have an ultrasound to these dogs and an FNA from liver and spleen and also a bone marrow aspirate in order to exclude, especially if these animals have peripheral eosinophilia, in order to exclude hypereosinophilic syndrome. And as you see, I was not trying to biopsy this first time. I was trying to see if there was a foreign body in the materials that this dog had ingested in order to remove it, but it was only hair and very, very soft. So as you see, it has some plastic things here as well, but very, very small. Nothing that could cause this magnitude of gastritis. And every time I go to the questions, my videos are stopping, so I'm not going to go. So as you can see, it is diffuse ulceration, and it's pretty active. It's ongoing and pretty active. It's not crater-like. You see that it's like linear ulcers, and it's not dotted, as I will show you later, but they're very, very fresh. They're red. Okay, and I'm trying to see if there are any other foreign bodies that could have caused this situation, but these foreign bodies are really, they look big in the endoscopy, but they're really, really tiny. They couldn't have caused this kind of ulceration. The primary cause was the eosinophilic gastritis, and the animal was swallowing things. It had pica just to alleviate this discomfort, this abdominal discomfort. Let's go to this one. And this is a cat with lymphoid hyperplasia. You see in the cat that the mucosa is much, much paler than the dog. Okay, and you see these lymphoid nodules, these nodules here. And there are a lot of other nodules in this cat, you will see that. And that was lymphoid hyperplasia. It was not lymphoplasmacytic gastritis, but it was probably due to food allergy or some kind of reactive disease. And this is the kind of biopsies that you have to get. You see that how much the biopsies are bleeding. This means that you got a very good chunk of the biopsies. So you've seen the nodules. Let me go to that again. They're not very prominent. These are whitish, these whitish nodules that you have to biopsy, and they are here as well. So they're in multiple places. Okay, and as you see, again, whenever I go to grab a biopsy part, I take all the air out so that all the mucosa comes up to my forceps. And this is why we take such a big grab. And in the stomach, you have to do this up and down movement a lot of times. Don't just force the biopsy out from the first grab. Just give it some time. Go up and down with your forceps so that it's cut evenly from the stomach and not left behind. Okay, lymphoplasmacytic gastritis. This is a very, very stressful diagnosis for all of the vets, because I know a lot of my colleagues actually call me a lot of times and they say, oh, this dog again has, mild lymphoplasmacytic gastritis or enteritis. What do I do with that dog? Do I give cortisone or not? Please, you can have an infiltration of lymphocytes and plasmacytes in the intestine and in the stomach due to other secondary, it could be reactive. This is what I mean. You could have another disease, and if you have a liver disease, for example, then the stomach and the intestine could be infiltrated by lymphocytes and plasmacytes. Okay, so you have to exclude the reactive infiltration in order to say that, yes, this dog has idiopathic inflammatory bowel disease. And do not give cortisone in very, very young animals. When an animal comes in, it's 6 months old or 8 months old, it could not have inflammatory bowel disease. Maybe food allergy. It's a more, consistent diagnosis. You see now these red dots. It's like this stomach has chicken pox. You will see them when I insufflate all the, now I'm taking out all the air and the saliva, and I have put my forceps. You can see these dotted areas. These are not ulcers. These are erosions. Okay, superficial erosions. And this is a very typical pattern of food allergy as well. I don't know if the age of this dog, because it's not written here. We have hidden the data. And you see that when we take the biopsy should be bleeding. And it's everywhere. It's diffuse. All these small dots. Okay. And you should take biopsies from each and every part of the stomach. So, is it idiopathic? Is it inflammatory bowel disease? Or is it something else that causes infiltration from lymphocytes and plasmacytes? So, could be allergy or food intolerance, could be toxicosis. Foreign body, when you have a foreign body, don't biopsy the stomach because the lesions are not representative. Systemic or metabolic diseases could cause infiltration of the stomach and the small intestine, and also other parasitic or infectious diseases. So whenever you biopsy the stomach and you have a diagnosis of inflammatory bowel disease, think twice before giving cortisone. And also always estimate the age of the animal. We will talk about IBD in a different lecture, and we will present a lot of cases with all the subcategories of IBD in order to know what to do and how to handle them, actually, and how to do in terms of management of therapeutic regimes that we use. Let's see, gastric ulceration and erosions. Could be, the gastric erosions are are mucosal disruptions that are not ulcerated, and the gastric ulcers are penetrating the submucosa. Sometimes we have a raised thickened border if they're crater-like ulcers, and they could have yellow necrotic tissue or a necrotic center. Never, ever biopsy the necrotic center because you will not have a result, you will not have a diagnosis. Okay, the neoplastic ulcers most of the times are single. They're located in the incisura angularis, this landmark that I have shown you, and they're crater-like. The ulcers from uremia and from diffuse gastritis are mostly diffuse, as I said, from gastritis are mostly diffuse. For uremia, I have some news for you, but I will leave it for later to tell you. And the ulcers from non-steroidals are mostly in the antrum. So this is the video of a Yorkshire Terrier that had a patella problem, and the orthopedic prescribed meloxicam as a syrup, and it only got 1 dose of meloxicam without gastroprotectant. And this is what happened. You can see the ulcers in the antral region, dotted ulcers in the antrum, and there was no duodenal ulcer in this animal. After the first dosage of meloxicam, this dog had fever, hematemesis, and melena, and beware of Yorkies. And also, when you want to give non-steroidals, please use some gastroprotection. What kind of gastroprotection should I use? This is another big subject. I know that most of you give PPI inhibitors like lansoprazole, omeprazole, pantoprazole, esomeprazole. They're not likely to stop the gastric ulceration. And here we see that there was no duodenal ulcer in this animal because you always have to pass the pylorus in order to see if there is a duodenal ulcer as well. So as I was saying, it has been proven that PPI inhibitors can only be used therapeutically and not prophylactically, and that the only agent that can act both prophylactically and therapeutically for non-steroidals is misoprostol. Okay, but we will talk about that in another lecture. So this is actually supposed to be a uremic gastritis, and I will tell you why I do not agree anymore, because there are some new data about that. So always biopsy the periphery of the ulcer, not the necrotic center. We've talked about that. And let's see a milder case of dotted ulcers. You can see these dotted ulcerated, this is the pylorus, and these are dotted small ulcers due to concurrent use of non-steroidals and glucocorticosteroids. Please do not do that. You know better than that now. We're better doctors than that. You cannot give cortisone and then switch it on to non-steroidals. You have to at least give 2 or 3 days in between. If you, for example, you have used non-steroidals and the animal's not doing well for an orthopedic, for example, reason, please leave at least 2 or 3 days in order to transition to corticosteroids. Okay. So you've seen the lesions. These are not dramatic. But these are only 2 days after the concurrent administration, and the animal started vomiting, actually over-exaggerated vomiting compared to the lesions that it had. So let's go to that. I'm very enthusiastic about that because we used to think that uremic ulceration was a reality and that patients with chronic kidney disease could have gastric hemorrhage. This is being questioned right now. We don't have enough data or enough research on that, but the preliminary studies, and this actually study, this research paper by Dr. Tolbert shows that they have measured the gastric pH and the serum gastric concentrations in chronic kidney patients and in patients that, mostly cats, and in patients and in healthy matched control, age matched control cats, and it was normal, which means that the pH was not acidic. If you don't have acidic pH, then you cannot have these cats that have chronic kidney failure, do not need acid suppressants because you do not have acid production in these patients. Of course, the limitations of this research, this is a huge, revelation because we used to give in all our chronic kidney patients omeprazole and esomeprazole and PPI inhibitors. And this has caused other problems, on the other hand. For example, diarrheas, because it has been proven that the PPI inhibitors, when given in given long term, they can cause diarrheas and can disrupt the microbiome of the intestine. So we try to use less PPI inhibitors in these days. So this is a revelation. We'll see if this is proven over the next years with more research. The limitation of this actually paper was that we had a very small sample size. I think that it was around 7 or 9 cats that were actually measured that had their gastric pH and their serum gastric concentrations measured. So we need a lot more research on that. But the preliminary evidence is that there is no gastric acidity in chronic failure patients. So gastric acid hypersecretion, this is from textbooks, and now all of these will be, maybe questioned about the uremia. Mastocytosis, yes, because we have the release of histamine. Gastrinoma, the pancreatic tumor, yes, because we have the release of gastrin, and this causes gastric acid hypersecretion and ulceration. And in terms of uremia, I've already told you that these all have been questioned. Let's see a gastrinoma, which is a pancreatic tumor. How do we do the diagnosis of gastrinoma? Certainly not with gastroscopy. In gastroscopy, the only things that you will see is deep ulcerations. These patients are severely diseased. They have intractable vomiting that cannot be handled with even the most potent antiemetic combination treatment. Even if you use ondansetron or dolasetron or maropitant, these patients cannot be treated. They keep on vomiting, and they have these very, very bad ulcerations. And the only way that you can actually detect the gastrinomas is to have a gastric to measure the gastric pH less than 3, and also to measure the gastrin concentrations, a very high gastrin concentrations, more than 20 units. Of course, every lab has its reference ranges, and it's very, very difficult also to detect the neoplastic tissue in the pancreas sometimes, especially in the beginning. You need CT scan, and even so, ultrasound, especially in early stages, cannot detect, because these are actually cells that are functioning in a problematic way and give high gastrin concentrations. Okay, And these dogs are presented with melena, with the hematomesis. Let me see if someone has raised their hands. Just seen someone. If it's by mistake, no, that's okay. Okay. Please feel free to ask. We're discussing cases here. If you have a similar case and you want to discuss it, we're here to discuss, not only showcase our cases. Okay. Mixed infiltrative gastroenteritis with Helicobacter. And as I said, we don't have Helicobacter pylori in dogs. We have the HLO's organism, which most of the times are not pathogenic, and they're bigger than the common Helicobacters, the ones that are named as Helicobacter pylori, for example. This is an intestine that has a bit of increased granularity, as you see. Do I detect Helicobacter in the intestine? Yes, you can detect Helicobacter in the intestine, and you can also detect Helicobacter in the liver as well. So you see here all these ulcerated, this is a severe gastritis, okay? And this animal is also eating foreign bodies in order to, this is not caused by the foreign bodies. This is due to the gastritis. As I said, these animals exhibit this tendency to swallow foreign bodies. And you can see that we have dotted ulcerations and diffuse ulcerations. This is the incisura angularis. And I'm trying just to remove, you know, some foreign bodies to alleviate the discomfort, but they're really, really tiny. And this was a mixed infiltrating disease, eosinophilic lymphoplasmacytic gastritis, which was inflammatory bowel disease, but very, very progressed. Okay, and the beloved bilious syndrome, which is very, very easily solved if it goes to your mind. Have you ever had these small Maltese dogs, you know, that their owners complain that they have green vomiting spots on their carpets every morning? This is bilious syndrome, okay? It has been shown in humans, dogs, and cats. In humans, especially in the newborns, it's normal, it's considered to be normal in very, very young dogs and cats because there is a reduced endogastric pressure and reduced pyloric contractions in the young kittens and puppies. The cause of the bilious syndrome is the irritation of the stomach due to the effect of the bile. So whenever I have duodenogastric reflux disease, the bile that gets into the antral region causes gastritis, okay? And this causes morning vomiting. This happens to the animals that are not fed some animals, not all the animals, that are not fed every 8 hours. So if their stomach is empty for more than 8 hours, around 12 hours, they have a morning vomiting most of the time. And of course, it has to do with the inability of the empty stomach to maintain the endogastric pressure, which is bigger than the duodenal pressure. Let's have a look at this. This is a cat, actually, but it's very well shown here. This is why I wanted to show it to you. So this is gastric content, and it tries to get into the pylorus, but it goes a bit out. So at some point, you will see that I'm trying to flush water in the pylorus to see what's going on, to see the contractions of the pylorus. Okay. And this is food that just, is just staying there, not going anywhere. So now I'm flushing, and you will see the regurgitation from the duodenum into the stomach again. So it goes in and it's spitting out again, as you see. This is very, very impressive because it goes in and then it goes, all the material is going out again in the stomach. Okay. And this is actually not yesterday, 2 days ago. a cat as well. And you're going to see what's happening to this cat. This is the incisura angularis. This is on the 13th of March. This is the incisura angularis. We have diffuse gastritis, and there's a suspicion of lymphoma for this case, but we are going to send it to the CT for a CT scan, and we did FNAs from mesenteric lymph nodes, and we took biopsies, and we're waiting for this cat. It's a cachectic cat, actually, huge, massive weight loss. You see that this animal has been fasted for 15 hours, and yet all the stomach is full of material. So now we're going into the pylorus. You see all the vessels in the cat. So this is the pylorus. And can you see here the movement from the pylorus is open, and all the content from the duodenum goes into the pylorus. I have to show you again. You see the flow of the content from the pylorus. It's coming out from the intestine. Instead of going the right way, it goes the other way round. Okay, this is bile coming out from the pylorus. So this cat has duodenogastric reflux disease as well. Okay. Gastric neoplasia, lymphosarcoma, adenocarcinoma, lymphoma. You will not see it in the stomach like that. It's a diffuse disease. Intestinal lymphoma and gastrointestinal lymphoma, you will only diagnose it with, most of the times, with full thickness biopsies of the intestines and FNAs from the mesenteric lymph nodes or from the spleen, if it's multicentric, from the liver. This is how you diagnose lymphoma. But for lymphosarcoma, where we see thickening and irregularity in the mucosa, adenocarcinoma, which is a very defined mass, ulcerated mass, most of the times in the incisura angularis, and the polyps that I show you later, you can have a preliminary idea from your endoscopic picture. And that's 1 month ago. That's a that's a Westie that hasn't lost any weight, but had periodical vomitings and anorexia episodes. So we got in, and this is a very, very early stage of adenocarcinoma. Most of the times we do not catch the disease. You see the ulceration here, and it's very, very well defined. This is the crater of the ulcer, and it's in the incisura angularis. So again, no pyloric infiltration in this case. This is a very early stage. Most of the times, I will show you how we find these carcinomas. And you see the alteration of the mucosa here. The mucosa the gastric mucosa has totally lost its normal structure. So most of the times, when we see adenocarcinomas, are like that. And right now, I'm thinking about how often I see adenocarcinomas, at least 3 times every month. So you see this deep, deep ulcerated area. This is a huge adenocarcinoma of an animal, of a Sharpei, actually. And we have this case in Aohua Vet. Please visit to see the whole case when we finish. You see the alteration of the mucosa here. The mucosa is totally abnormal. And there is also an infiltration of the pyloric region. This dog had to endure total gastrectomy, which was not possible. And you saw how big the ulcer and how deep the ulcer was. Have a visit in Aohua Vet and see the whole case and what we did. This is how most of my adenocarcinomas look. The prior case of the Westie was an exception. It was not the norm. And let's go to the intestine. We finished with the stomach. We're going to have a lot of lectures on certain diseases of the stomach and intestine. So we're going to go into more depth about management and about diagnosis and diagnosing modalities. alongside with the endoscopic modality as well. So the duodenum, the mucosa is pink. It looks like velvet. Sometimes it looks like the corals of the in the sea. The submucosal vessels are not visible in the small intestine, where they are visible in the large intestine, as we will mention later. So in dogs, we have the major duodenal papilla, where the common bile duct enters, and the minor. We have two papillas, and the minor duodenal papilla, not in all dogs, but most of the dogs. These are small white protuberances. I will show you. Most of the times you will not see them. You will lose them because you enter the duodenum with force and you try to proceed. So you don't see these papillas. Most of the times they're visible when you withdraw back to the pylorus. In cats, there is no minor duodenum papilla. And of course, always watch, the Payet patches. Do not biopsy the Payet patches. These are visible as oval depressions in the duodenum. Okay, this is the major duodenum papilla. These are the Payet patches. These are like depressions in the mucosa. And if you biopsy these areas, you will find so many lymphocytes because these are, really rich in lymphocytes, and it will give you a wrong impression of the disease that your animal has. And this is the normal mucosa. The normal mucosa looks like velvet, looks like, smooth, no irregularities, no erythema or hyperemia, no erosion, no ulcers. And another thing that I want you to be aware of is that when you go into with the endoscope, if while withdrawing you see linear lesions, then it's you have caused that. Okay, it's not lesions that were there in the beginning. So let's see a normal small intestine in a cat. You see that everything in the cat looks more pale. Okay, and this cat has trichobezoars, hair, always cats licking hair. So you could have going in when you go from the ascending to the descending duodenum and then to proceeding in the intestinal lumen, you will have some areas of a red dot. This is an area of a red dot of the curves in order to find your lumen, and you should always get into your lumen. There are two biopsy techniques. The first biopsy technique is the blind one, that you just proceed your forceps up until you don't see your forceps, and it makes a curve. And this was a peristaltic wave now that you saw in the intestine. So you proceed your forceps up until you do not see it anymore, and you take blindly the biopsy. Most of the time, this is the way, this is the one that I'm showing to you now. I'm just proceeding with no visibility. I don't like taking these kind of biopsies because they're smaller. You do not know where you're biopsying. And most of the times, your biopsies are really, really small. The other technique is that you go out of the endoscope and you just have your forceps very, very close to the endoscope, and you do 90 degrees on the mucosa. And this gives you better control of the intestine, better control of your scope, and better biopsy punches. Okay. So you take your biopsies while going out. Now I'm trying to do the close technique. You see how close my forceps is, and I go. Now you don't see anything because I go into the mucosa. And also, I take the air out so that it comes up to me, as I said before. And you see how deep this biopsy was. Okay, this was a close biopsy. So we have these two techniques. And I'm taking from every part of the intestine as I go out, as I am withdrawing, first from the intestine and then from the stomach. Okay. Why do I take biopsies if I say that this intestine seems to be normal? Because I have to. You will never have the chance to do it again. So you will take your biopsies and you will send them, even if you don't see any microscopic lesions. Okay, and then I withdraw to the pylorus, back to the stomach. You see some glistening. This is a bit edematous because it's very, very glistening, and it shouldn't be that glistening in the intestine. Okay. And this is the procedure. We withdraw a bit, take a biopsy. We withdraw a bit and take a biopsy sample. This is a bit rare to have a duodenal ulcer in a cat, and we have no clue. This was a neutrophilic ulcer, actually, maybe due to a foreign body that was preceded. This is duodenum, and you see a big ulcerated area in a cat, maybe due to a foreign body because it was a neutrophilic, it had a neutrophilic infiltration. It was not neoplastic. Okay. So we try to take a biopsy, from the periphery. Again, you see how deep the ulcerated area in the duodenum is, and this cat was not on non-steroidals. So you always have to ask about toxins, about drugs, administration of drugs, about everything. Inflammatory diseases, infiltration of lymphoplasmacytic infiltration, eosinophilic infiltration, neutrophilic infiltration, or mixed infiltrations. What do we see? Most of the times we see granularity, increased granularity, friability, hemorrhages, erosions, reduced peristalsis. Beware of the linear hemorrhages, as I told you. Let's have a look. Can you see these white membranes? You see the irregularity. These are not digested, undigested materials, and it's not lymph. Because you will see that the same material is in the stomach as well. So we see an irregularity of the mucosa, and this is a mild case. We have more prominent cases that I will show you. So you withdraw and take biopsies, withdraw and take biopsies. Here the area is a bit better. And then you go out to the pylorus. Let's see some more severe cases. Okay. And if I show you the next 3 videos, can anyone tell me which one of them is progressed IBD, lymphangectasia, or lymphoma? No, you cannot endoscopically. They're exactly the same, exactly the same. Severe IBD, lymphoma cases, and lymphangectasia sometimes, because with lymphangectasia, we can have other clues as well, have the exact same microscopic image. So let's see that one. This is a severe IBD, moderate to severe. The lesions, the infiltration that came out was moderate to severe, lymphoplasmacytic. And this was one of the, and also this dog had low albumin count as well, low cholesterol. You always measure these in intestinal diseases. You've seen how irregular the mucosa is. Lymphangectasia, always look for the secondary. We have the primary lymphangectasia, which is idiopathic or congenital, and we have the secondary. The secondary lymphangectasia could be localized in the intestine due to IBD, due to small intestinal neoplasia, like lymphoma, for example. And also, you should always check, if you find intestinal lymphangectasia, then you should always check the heart. Maybe we have a congestive heart failure, or we have some other kind of diseases. And these are the breeds, especially the Yorkies and the Rottweilers, are very, very prone to lymphangectasia cases. And this is the lymphangectasia. And what are the endoscopic? You see here the lacteals, multiple white spot indicating that we have dilated lacteals. We have these white spots and also these whitish spots. Most of the times when you go into endoscoping a lymphangectasia case, you know that it has lymphangectasia. But you trust trying. We have a normal peristalsis as well. Never, ever scope an animal that has a recent meal because it might look like it has lymphangectasia due to the dilated lacteals. Okay. And of course, this animal had small intestinal diarrhea. Very low albumin count, protein losing enteropathy. And then we had these cases that were not that severe and that had these white spots areas, either with a variation in distribution, a lot of white spots, less, few, or moderate white spots in the intestine. And then we were wondering, these animals are not severely diseased. What are these white spots? Are they distended lacteals as well? No, they were like some of my residents used to tell me that are these rice that the dog did not digest? And I was saying, no, this is due to low albumin count. And they have made, this actually was published in 2011, the white spots in the mucosal surface of the duodenum. And what do they mean? So these snowflake-like or rice grain-like lesions are indicative of low serum protein and low albumin concentrations most of the times. And they're not an exclusive finding in intestinal lymphangectasia. You can have these spots without having intestinal lymphangectasia if you have low protein counts. Let's see this dog here. This is pretty amazing. This is extraordinary. Do you see these white spots? So this dog does not have lymphangectasia. It just has a low protein count. And we actually diagnosed that because we took biopsies and we confirmed that this was not a lymphangectasia case. But you can see how prominent these white spots are. Actually, my colleagues were right. They look like undigested rice, like this animal had a can of, clinical diet and it could not digest the rice. The image is extraordinary. And of course, if we want to comment on the mucosa, you can see the irregularity, but not very, it's not a very prominent case. And it was very friable. In biopsies, the friability was really prominent. Okay, so whenever you see those white spots, I hope that you had the preliminary workup, blood work, and that you already know that your dog has low protein count or even borderline low. It doesn't have to be a hypoalbuminemic state. It could be just borderline low, and you will see these white spots. And this is a lymphoma case, which is pretty much the same as a severe IBD case. You see the increased granularity and friability. When we talk about intestinal neoplasia, we can have polyps, leiomyomas, adenomas, fibromas, and of course, malignant lymphoma with a more diffuse thickening, like the severe IBD, and adenocarcinoma. But this was a lymphoma case. You can see the irregularity of the mucosa. It was very friable whenever you wanted to biopsy the mucosa. It was very I mean, you got a whole chunk of the intestine. Okay. These are severe cases that you understand, even if you're not experienced, that they are really, something really bad is going on. And this is a pellet in the duodenum, undigested. Okay, this is a pretty amazing picture. Let's go and see what happens. And I think that's pretty much my last case. You can see this case as well in Aohua Vet. This was a case of a dog that had intestinal obstructions from a seed, from a fruit seed. Sometimes when you have intestinal obstruction, you can miss it in the ultrasound, but you will have an animal that starts getting hypoalbuminemic. You will see in the ultrasound in the intestinal loops the content to be regurgitating, to be going back and forth and not to be proceeding. And you will have gastric retention of fluids and also intractable vomiting and projectile vomiting. The animal will not be able to digest anything. So as you may see, this is severe esophagitis, stage 3, because it's in circular forms and in linear forms up to the pharyngeal esophagus. So this dog has been vomiting for more than 2 weeks, and this has caused severe esophagitis. And you will, of course, no ulceration, but when we have linear lesions in the circumference, then this is stage 2 to stage 3. And you will see now with Aohua endoscope, we have the ability to turn the hemoglobin on. It's very prominent. And now that it's on, this is the hemoglobin enhancement, then you can see better the esophagitis status and all the erosions and lesions. Okay. Now they're very, very clear to you, and it's throughout the length of the esophagus. So if we go into the stomach, you will see that we have huge gastric retention. And you say something is wrong. I mean, this gastric content, it's like a pool. There's somewhere there is an obstruction. Is it in the pylorus? Is it in the intestine? This is something that you will find out. And it was not in the pylorus. So when we went into the intestine, you see that the intestine is pretty normal. This poor animal has not an intestinal disease. Give me some minutes to have the vision cleared, because we have a lot of retrograde movement of the intestinal fluids, of the duodenal juices, because they cannot be forwarded. So I have always to suck, and this is where the foreign body is embedded. And this is a seed from an apricot, I think. Can I retrieve the foreign body from the intestine? Don't ever do that. No, this is a surgical case. We can retrieve foreign bodies from the stomach. We can never retrieve foreign bodies from the intestine. Okay, it's very dangerous. And this was actually, this has gone to surgery with enterotomy, and the foreign body was retrieved. And the dog was happy again to swallow more foreign bodies and make us rich. So this was pretty much everything. I hope that I was on time this time, Jason. And if you have any questions, I'm more than happy to discuss with you your cases, your questions.
Yeah,
Thank you. Thank you all for attending.
Feel free to ask any questions. Maybe you can learn more things after our webinar. We have Facebook, YouTube channel, and LinkedIn, and we also have some clinical cases in our YouTube channel. You can search Aohua Vet on YouTube to subscribe us to find more clinical knowledges. And I thought maybe you guys want to know our first webinar. Maybe you missed it. Don't worry, we will upload our webinar record on our YouTube channel. And the first webinar record has been uploaded. And today's record we will upload later.
Thank you very much, everyone, for attending, everyone from all over the world. And if you have any questions, please do not hesitate to contact me. Visit Aohua Vet, because every month we will be uploading clinical cases, and not only the endoscopic part, but the whole diagnostic approach part. And whoever missed the webinar can actually rewatch it again. And we will be every month here to, just to build up a community and discuss our cases. Please, next time, bring your cases as well. We will announce the topic. And if you have relevant cases that you want us to discuss, do not hesitate. This is why we're here. We are here to exchange, as Jason said, ideas. We are here to build up a platform of open discussions and, to ask questions without being hesitant or shy, because we're all here to learn. Thank you.
Thank you, Vasilikhi. Thank you for your brilliant presentation. So hope we will meet next month.
Yeah, and also, if you have any suggestions of the topics that you would like me to present, not only in gastroscopy or colonoscopy that we have it ahead, in other kinds of scoping, like bronchoscopy, rhinoscopy, please tell put your demands, and we will do it for you.
Yeah, please contact us on each channel you like on Facebook, LinkedIn, on YouTube. So today is over.
Thank you, everyone.
Yeah, thank you.
Greetings from Greece, and I will see you next month. I do not know from which point of Earth I will be, but in which country I will be, but we will be together.
Yeah. Okay, see you next time.
See you.
Bye.
Bye.